There is some sweet irony to the fact that our final speaker of the academic year is an intern who is going to be a resident just in a few days. I am really so excited because already people are like, who is this? To welcome Dr. Morgan Birabaharan. And I'm just going to say Dr. B,
yeah.
But thank you. And he'll say it himself also, so it's burned in the brains for everyone. Who is currently an intern, will be a resident in the internal medicine. He's a physician scientist, or he's in the physician scientist training pathway, will be an ID fellow in just a year. So we're really excited that Morgan will get to stay with us. Or I guess there still is there's supposed to be some sort of interview process for that, but we know he'll be with us. He's fabulous. So his research interests have been using large population databases to help investigate metabolic complications and elucidate sex differences in the aging HIV population. His future academic interests entail utilizing large epidemiologic findings to guide translational medicine discoveries. He's been really fortunate to be here at UC San Diego to pursue this path under the guidance of world-renowned experts, and through the resources of one of the highest impact HIV research institutions worldwide. We made him write that. No, I'm just kidding. But also, if you Google Morgan, you'll see he's been busy in his intern year and before writing and publishing. So this is definitely a person to keep an eye on. And we're really excited to have Morgan present to us, Dr. B. For everyone, just put questions in the chat or directly to me if you have questions. And with that, I will hand it over.
Nice. First and foremost, Dr. Blumenthal, thank you for that kind introduction and kind words. On behalf of our team, we are truly grateful for the opportunity to present our work with you all today. This topic to be discussed has been a true passion of ours for many months, even years, and it is and to be given the chance to share our journey, to share our journey with you all, is a truly humbling experience. And so, on that, I have no conflicts of interest to disclose, and we start off with our first slide. And so this picture here encapsulates how I feel every morning waking up. And that feeling is that we are in uncharted territory, and that for the first time ever, we are witnessing people age with HIV. Everyone in this audience probably knows it better than I do, that HIV was once a death sentence. But because of the success of antiretrovirals, we're witnessing people live with HIV for decades at a time. All of this, though, comes with a question. And that question is, are there consequences? Are there consequences of living with this virus for decades at a time? Are there consequences of having to take these antiretrovirals for decades at a time? The answer is a resounding yes. That people with HIV will develop chronic diseases at a much higher rate than the general population. And worryingly, they will develop these diseases at much earlier ages. We can appreciate that people with HIV have a strong association with the development of neurocognitive disorders, with cardiovascular disease, renal disease, bone disease, and malignancy. There's something to be said, though, about the studies that establish these relationships. And that is, these studies were done in predominantly male cohorts. And so here comes the next question. Is there any reason to think that women with HIV age differently than men? My promise to you all today is that you will gain further insight into this very question. This talk is outlined in 5 parts. First, we'll talk about the sex differences and the immune response between a man and a woman. We'll then illustrate the clinical relevance of these sex differences in no other disease than HIV. We'll talk about the current landscape and sex differences in HIV aging. And then again, very grateful for the opportunity to share the work of our team in regards to sex differences in HIV and diabetes. We'll talk about the steps moving forward from here. And so for part 1. And so for any talk on sex, it is important to distinguish what is the difference between sex and gender, because these two terms are often used interchangeably, but they are two distinct entities. Sex is our innate biological differences. It's driven by gene expression. It's modulated by sex steroids and subsequent downstream pathways. Gender, on the other hand, is our interaction with the environment, the cultural environment, and it's impacted by lifestyle factors such as stress, diet, and sexism. For the purpose of brevity, this talk will only entail sex differences. But keep in mind that whatever sex difference we talk about, gender is intertwined. And so this slide here, the purpose is to delineate the biological differences between the immune response between a man and a woman. And there's no better way to do that than the way in which Dr. Eileen Scully, a thought leader in sex differences in HIV and diabetes, did in her review published in 2018. And so the first thing to acknowledge is that the immune system of a woman must be different from a man. And that is because of different evolutionary pressures. The woman must be able to undergo immunosuppression to tolerate pregnancy. After pregnancy, a woman must have the ability to pass down immunity to the newborn fetus. These are two evolutionary pressures that a woman has to undergo that a man doesn't. For that reason alone, we can expect the immune system to adapt to be differently. But what are the mechanisms at play? How is it that a woman is able to have a different immune response than a man? Dr. Scully illustrates 6 different ways in which this can occur. The first is genetics. A woman has 2 X chromosomes, while a man at birth has XY. Understand the X chromosome harbors critical immune regulatory genes, such as TLRs, which are a microbial sensor, and is the receptor that senses single-stranded RNAs, which includes viruses like SARS-CoV-2 and HIV. The second is anatomical differences. Understand that the female genital tract is an anatomical compartment in which there is no male equivalent, and it's unique, and that it alone can explain unequal risk for acquisition of multiple diseases. The next is immune cell phenotypes. If you look at the immune cells of a woman, at times there's higher expression of certain receptors that we don't see in men. For example, as previously mentioned, toll-like receptors. Studies have shown that in women immune cells, these receptors are expressed at much higher levels. Then there's epigenetics, which is our ability to turn on or off certain genes. If you look at the genes of a man and a woman, they are largely identical. And so many scientists have said that it's our ability to turn on or off certain genes that give us the 2 distinct phenotypes we see in the man and a woman. And lastly, there's the microbiome. And I think we can all appreciate that the microbiome has an undervalued role in the function of our immune system. At the center of all this is sex hormones. And sex hormones impacts each and every one of these mechanisms. And so estrogen has been shown to alter a microbiome. Sex hormones have been shown to help regulate the gene expression. And sex hormones have been shown to increase inflammatory responses from our immune cells. And so to be honest, I read that and I still wasn't convinced sex differences exist in the immune response. I'm a chemist by training. And so to me, there must be a mechanism in play in order for me to believe in something. And I just want to walk you through the one mechanism that convinced me that sex differences are very much real and it's something that I could pursue in my life's work. And so classically, we think of a woman at birth as having 2 X chromosomes. Classic teaching is that one of these X chromosomes gets inactivated during embryogenesis. The reason for this is to balance gene expression. But this is simply not true. Many studies have shown that genes on the second X chromosome still get expressed. But then what extra genes are being expressed on the second X chromosome? And they're what were previously mentioned. Many critical immune regulatory genes. We have here TLR7 or 8, which is the receptor for single-stranded RNA for viruses such as HIV and SARS-CoV-2. We have FOXP3, which is an essential transcription factor for the function of regulatory T cells. And then we have other genes listed here. And these genes have been shown to be vital in the production of antibodies against vaccines and our fight against bacterial infections. So without a doubt, it might seem that women get an advantage with the immune response. And so I want to walk through an example clearly to really convince us all. So imagine we have TLR7 here, our receptor. When we stimulate it with single-stranded RNA, we produce interferon. And interferon is our body's first line of defense against viral infections. So for women, we might suspect that they have higher expression of TLRs, and therefore they have higher expression of interferon. Could this mean that women have a better have better antiviral immunity against viruses, right? Have better antiviral immunity. And so I want to illustrate what's going on with COVID, and that men are disproportionately impacted by SARS-CoV-2 infection in terms of who acquires it, who gets hospitalized by it, and who dies from it. This is not just in the United States, this has been across the globe and across all age groups. Many experts, as listed below, have stated that could it be the differences in our interferon response between a man and a woman that explains the unequal impact this infection has had on society. And so at this point, I hope we can appreciate that biological differences in the immune response between a man and a woman exist. But now I want to hone down on the clinical relevance, and there's no other disease better to do that than with HIV. In every part of HIV, sex differences exist. And so what I want to do is I want to go through the moment in terms of acquisition, in terms of how it lives in the body and progresses, and how it responds to treatment, and illustrate that sex differences exist in each and every one of these steps. And so here's a statistic that I think we all came across once in our lives or once in our training. And it's the idea that women during a heterosexual encounter are twice as likely to acquire HIV than men. There's a lot of factors at play here. You know, there are socioeconomic factors, there are behavioral factors, but I do want to get across that there are biological factors at play as well. And that biological factor is the female genital tract. Understand this is a unique anatomical compartment and that there is no male equivalent. It is an extremely complex immunological milieu, and it can be impacted in many ways that would increase the risk for HIV acquisition. The first is inflammation, which commonly comes in the setting of STIs. Multiple studies have shown, and some that I've cited here, that bacterial vaginosis, herpes simplex virus, infection within the female genital tract can increase the risk for HIV. Some studies have even shown that an infection such as HPV will increase the risk for HIV among women, but not men. The second way in which the female genital tract can be impacted is sex hormones. And so there are phenomenal bench science studies showing that progesterone in particular can increase the number of target cells at the cervical vaginal mucosa. Secondly, studies have shown that progesterone can increase the level of receptors on these immune cells. And these receptors are critical for HIV entry. And these include CXCR4 and CCR5. Now, I do want to say that many have seen these bench science studies and were concerned that contraception can increase the risk for HIV. I would say that has been largely controversial, and that just understand this is mostly just what's been shown on the benchtop. And last, we have the vaginal microbiome. And so many studies have shown that microbiomes that are lactobacilli deficient or that have high diversity in terms of a bacterial vaginosis infection increase the risk for HIV. And so what I hope we've shown here is that women have a unique anatomical compartment which alone can be impacted in many ways that increase the risk for HIV in ways we don't see in men. So we talked about HIV acquisition. Well, let's talk about the moment that HIV is now in the body and there's no antiretroviral treatment. Do sex differences exist then? They do. So here I want to get across the fact that women have a lower viral load than men. And so here's a study done by Dr. Monica Gandhi. And this is a meta-analysis of about 13 studies. And what this study showed was that women had a twofold lower level of HIV RNA than men. But let's move on to the next study to really figure out what's the importance of this. And so I want to put this study into perspective. It was done about 2 decades ago. This study was done at a time where the decision to start antiretrovirals was done based off the viral load. If it was at a certain threshold level, you would start antiretroviral treatment. But if it was below that, you would hold off. Well, then let's look at the figure on the right. And what we see here, understanding that women have a lower viral load than men, is that despite that, women and men progress to AIDS at the same rate. And so who cares that women have a lower viral load? They're still progressing to AIDS. But what this study is showing is that many of them will never have qualified for ARVs based off those current guidelines. This study cited that among all the women that progressed to AIDS, only 34% of them qualified for ARVs. In contrast, among all the men that progressed to AIDS, 74% of them qualified for ARVs. So here was a clear clinical mismanagement, and it was because of a sex difference that was unrecognized at that time. And so again, let's continue on this path. The virus is inside the body without any ARVs. The next sex difference to talk about is that there is discordant rates of inflammation and that women with HIV experience much higher levels. And so this is a study done in the lab of Dr. Marcus Alfeld at Massachusetts General Hospital. And what he did was he got plasmoid dendritic cells from both healthy men and women without HIV. He then stimulated those cells with HIV RNA. And the results are what we see here on the right. And that women have much higher levels of interferon response than men. And so this gets across the idea that inflammation is much higher among women. I want to continue reinforcing this idea. Here is another study. And so this study is men and women with HIV who have not received antiretrovirals. What they did here was get many cell lines and then measure the expression of interferon stimulated genes. And on the figure on the right, hopefully self-explanatory. And that for women, levels of interferon stimulated genes is higher in all cell lines for women compared to men. So hopefully this is convincing that when the virus is inside of women, there is much more inflammation going on. The last thing to mention is that even in unique cases, there has been cases of people having the virus and controlling it without the need for antiretrovirals. We have often referred to these people as elite controllers or long-term non-progressors. What I want to share here is that people who are able to do this are more commonly women. And so here's just one study. This was a cohort study from the Cascade trial, and the Cascade was an international collaboration between sites from Australia, Canada, and Europe. And what they wanted to do was find out what factors were associated with people who were able to control their virus without the need for ARV. And so here we see that women, after controlling for many confounding variables, were 2 times more likely than men to exhibit this unique immune control. And so clearly, when the virus is inside of a woman, it is different than when HIV is in a man. But now let's start ARVs. Do sex differences exist then? The answer is yes. Side effects were common with older ARVs, but they were even more common among women. And so I just want to share this study here in terms of the use of nevirapine and NRTI and how women were 7 times more likely to have a rash from this medication. This rash did not come without consequences. Because of this rash, women were 3.5 more likely to discontinue ARVs. Let's continue on this theme. And so here I have a review paper written by Dr. Afodikun. Dr. Afodikun is probably the name you should think of when it comes to sex differences in antiretroviral medications. Here he lists some interesting facts, and that a feared complication with older ARVs was lactic acidosis. Not only did lactic acidosis disproportionately affect women, but when they were fatal, they were almost unanimously women. 85% of fatal cases were among women with HIV. And then of the many other side effects, lipodystrophy, hepatitis, metabolic derangements, and GI toxicity, understand these all disproportionately affected women. Understand that when you have a side effect, you're more likely to discontinue antiretroviral treatments. And for this reason alone, I think we can suspect that simply women with HIV did not get the best care during the use of these antiretroviral medications. And so what I hope at this point is that we can appreciate that sex difference is widespread in HIV. They exist in terms of who acquires it. They exist in how the virus progresses in the body, and they exist in how it responds to antiretroviral medications. Sex differences exist many other places. I'm sure Dr. Blumenthal can talk about the sex differences that exist in PrEP. I'm sure Dr. Gianella can talk about the sex differences that exist in HIV reservoir. So if sex differences exist in every aspect of HIV research, the question is, what are the sex differences in HIV aging? And so that's where we move on to our next part of this talk. So I'm sure on this slide, everyone here wants me to share the research on the sex differences in HIV aging. My question back to you is, what research? No, it is my quote unquote professional opinion, where there's simply not enough research being done on how a woman with HIV may age differently than a man. I hope to convince you that this is the case. There's a study that I performed on my own. And this study borrows from the methods of a study led by Dr. Monica Gandhi. And she did this in a collaboration with some of the biggest names in HIV research, of who Dr. GNL is included. And what they did in that paper was they looked at CROI at a certain year, and they looked at all the oral abstracts. And they said, okay, among these oral abstracts, how many of them mention sex as a variable? And they took it one step further. How many then looked at sex-specific analyses? The theme of that paper was that sex differences was rarely evaluated in the biggest conference for HIV worldwide. And so I want to borrow those methods and do this study here. So what I did was looked at for 2021. I pulled every abstract that I thought was relevant to HIV aging. And so these studies were often epidemiology studies, trying to establish an association or the prevalence of a certain chronic disease with HIV. A lot of these studies were translational. They may have looked at biomarkers to help prognosticate the risk rate for a certain disease. And lastly, some of these studies were looking at therapies, in which case, can we use these therapies to mitigate the development of many of the chronic diseases that we are worried about? And from these abstracts, from all the abstracts, there were about 106. And so what we can do at this point is just the audience can think to themselves, of these 106 abstracts, how many do you think mention sex as a variable? Meaning at the bare minimum, they might have said blank percent of participants were men, blank participants were women. And so quick thoughts, everyone, to themselves.
Oh, I shared.
Oh, sure.
If people want to put them in the chat, I can tell you some of the, okay. I said 10, and I guess I meant 10%. Someone said 50%.
Oh.
That's what we have. We have somewhere
Cool.
between 10 and 50%.
Absolutely. No, those are much better numbers, actually, or much worse numbers. The numbers itself is much better. And that about 75% mentioned men or women as a variable, meaning their demographics, they said, 75% were men. And so I was going to try to pitch that 25% of these abstracts don't even mention sex as an important thing to consider. But then there's the next step. Among all these studies, how many of them performed sex-specific analyses? Meaning they looked at women with HIV and try to gauge whether or not their therapies or the epidemiology may differ from a man. And again, we can think to ourselves, just to pull the audience, I can just maybe wait 2 seconds or.
Yeah, I think now we're both, the two of us who responded are now saying it's about 10%.
Yes, all right, good, you got it, around 10%. Only 10% of these abstracts even entertain the idea that women with HIV may be aging differently than men. I might have exaggerated when I said there's no research being done, because some people, I'm sure Dr. Tender may mention that sex differences exist in neurocognitive disorder, and sex differences may exist in the development of cardiovascular disease. But what I want to get across is that there is so much more that we should be worried about. And there's no better way to do that than talk about what was shown in the ADVANCE trial. And so the ADVANCE trial was the way in which the WHO was going to introduce the use of modern antiretrovirals in developing countries. And long story short, it was a largely a success, that the use of integration inhibitors along with TAF was non-inferior to the older regimens. But that is not the reason that the ADVANCE trial is still talked about today. The reason it's so, in my opinion, it's so popular is what I'm showing you here. So let's focus on the graph on the left. And so what we see here is that with the start of these new modern antiretrovirals, there is weight gain. This weight gain, though, plateaus. And so this is normal. This is what I think many would refer to as the return to health phenomenon. That people with HIV are no longer in this catabolic state after the start of ARVs, and we expect weight gain. But then let's look at the figure on the right. And what we see here is something worrisome, and that there is weight gain among women with HIV that exceeds men, but there's no sign of a plateau. It continues indefinitely up until the final week in which these participants were monitored. And so here, this figure gets across that there might be disproportionate weight gain among women with HIV. I want to reinforce the findings of this study with a study then that was led by Dr. Paul Sachs. And so what this study did was pulled the data of 8 randomized controlled trials. And so these are trials, this data is probably the highest quality. And this study demonstrates the same findings that we found in the ADVANCE trial. and that with women with HIV experience higher rates of weight gain than men. We were then even able to stratify this by race. And we see that Black females disproportionately gain more weight than their counterparts, as well as men. And so what I hope we can appreciate now is that there is excessive weight gain happening with women with HIV. And this is concern number one. Concern number two is inflammation. I mentioned previously that when HIV is inside of a woman, there is more inflammation happening. What I want to get across now is that when you start ARVs, the picture doesn't change. So here's a cohort study, and this was done in a group of people with HIV in Peru. And what they show here is measure the inflammatory markers, so CRP, before any ARV is started, and then measure the levels of CRP 2 years after ARV is started. And we can start with what's shown in the men and what we expect to happen, and that CRP decreases after the start of ARVs. But let's look what's happening among women with HIV. The level of CRP remains mostly the same, and then for some cases, even after the start of 2 years of ARVs, the levels of inflammation go up. We then move on to the next inflammatory marker. And so this is SCD163. This is a general inflammatory marker that's been shown to be associated with the development of diabetes as well as metabolic syndrome. And what we see here is that it's high in both men and women before ARVs. With men, after the start of ARVs, we see that this level decreases. But for women, we see that it decreases, but to a much lesser degree. In fact, after 2 years of ARV, their levels of SCD163 is comparable to the levels of SCD163 before any ARVs in men. So here we get across that inflammation in women with HIV is less responsive. Let's continue along this theme. And so here is probably one of my favorite studies from February 2021. And what this study did was it looked at a group of men and women with HIV and looked at those who experienced a myocardial infarction, a stroke, or a venous thrombotic event. And they measured a panel of inflammatory markers. They found which inflammatory markers were elevated in those who experienced an MI or stroke or a venous thrombotic event. And those inflammatory markers are listed on the left here. What they then did was see who expressed higher levels of these worrisome inflammatory markers. And what we see here is fascinating, and that women with HIV are experiencing higher levels of these inflammatory, are mostly experiencing higher levels of all of these inflammatory markers, with the exception of 2. And so again, we are continuing on this worrisome theme that there is much more inflammation happening among women with HIV. And this is the last study that I want to show in regards to inflammation. And I just really want to focus the figure on the right. So this was done at Massachusetts General Hospital under the leadership of Dr. Stephen Grinspoon. And what they did was just measure the levels again, SCD163, which, to remind us, is an inflammatory marker that's been associated with the development of insulin resistance, as well as the metabolic syndrome. And what we show here in the right-hand columns is those with HIV infection. We see that for women, this inflammatory marker increases with age, whereas for men, it essentially increases a little bit, but then even plateaus or decreases as they get older. And so not only is there high inflammation in women with HIV, but this only gets worse as they age. And so hopefully at this point in the talk, we're all convinced that there's excessive weight gain happening among women with HIV. And secondly, there's excessive inflammation. And so with these two combined, is there something that we should be worried about? And I hope we can appreciate that one thing we may be worried about, among many others, is diabetes. And so that takes us to the next part. And this is the part.
Can I just interrupt you for 1 second? There was a question that came through for the sex differences in aging. Are the studies controlling for viral load?
Which study are we referencing to?
I don't know. Probably, I'm going to get many of them. Go ahead.
Yeah. So my question is, for all these studies about inflammation, are they controlling for viral load?
So I can say for sex studies, for this one that I have shown here, there is a control for viral load. I honestly would not be able to reference the 2 other studies, but I can review that and get back to you. And I would agree that it would be something important to control for.
Thanks.
That's good. So I appreciate it. So then at this point in the talk, I'm very proud to share the work of our team in regards to what is going on with sex differences in HIV and diabetes. I understand that diabetes and HIV is extremely controversial, and that for every study stating that there is an association, I promise you that I can find you a study that says that there isn't. So what I have listed below here are some of the seminal studies, what I thought really captures where are we at in this field. I just want to take the time to review 3 of these studies, because these 3 studies are from large cohorts, famous cohorts that have high quality data. I think we can appreciate where the field is just from the reviewing of these 3. So the first is the MAX cohort. So this study was led by Dr. Todd Brown, who is probably the name you should think of when it comes to HIV diabetes. It was done probably about 2 decades ago. This study showed that people with HIV developed diabetes 4 times at a rate of 4 times the rate of the HIV unaffected cohort. And so I think it was this study alone that really told us that there might be a strong association with HIV and diabetes. But this study has limitations. First and foremost, the MAX cohort is all men. There is no women representation in the study, so who knows what's going on with women with HIV? The second thing to consider is that they only adjusted for age and BMI. And so I think this might not have been appreciated 2 decades ago, but we now know that there are many reasons as to why someone with HIV may develop diabetes. For example, smoking, alcohol use, substance use. These are many other factors to consider. And lastly, this was done in the era of toxic ARVs. This study, a lot of patients were on diamidine analogs. So that alone, those medications were known to be mitochondrial toxic and cause insulin resistance. And that was the reason why diabetes was so common. So a big question is, if we repeat the study now with the use of newer modern antiretrovirals, is the association between HIV and diabetes still there? I want to get across this study. So this is from the veteran aging cohort. And this is a study led by Dr. Amy Justice, as well as Dr. Adil Butt, first author here. And so this study is a little different from the study that we just shown, in that they controlled for many confounding variables. In addition to controlling for age and BMI, they controlled for race, smoking, alcohol use, hepatitis C. And what they found was what I have highlighted here, and that diabetes is not higher among people with HIV. In fact, it was lower. Again, I just want to mention the one limitation of the study that is unfortunately common with studies from the VA, and that it was predominantly all men. And so we are still left in the dark in regards to what is happening with women. So then here comes across data from the Weiss cohort, and this was led by Dr. Lauren Collins, who was a fellow at this time. And what they found was something startling, that in their study with all women with HIV, that the prevalence of diabetes was not different between those with HIV and those without HIV. Well, let's mention the limitations for this study as well. First and foremost, their control group had high comorbid burden, meaning those without HIV had higher rates of obesity, hypertension, hyperlipidemia, and smoking. And these were all reasons as to why the control group may have had diabetes at higher rates or at such high rates. The second thing is that there was no logistic regression to control for confounding variables. And so one can say that if they were to control for these confounding variables, that the prevalence of diabetes might have been higher in the HIV cohort. And so what is needed now, knowing the limitations of the past studies, in order to really understand what is going on with HIV and diabetes? Well, first, we need to reevaluate this association with the use of modern ARVs. Second, we need to have a large population, because there are many reasons as to why someone with HIV will develop diabetes, and we need to control for these confounding variables. And lastly, we need to have adequate women representation, perform the necessary sex-specific analyses to understand, does women with HIV age differently than men? And so we now come to our study, and our study focuses on the population database of Explorers. And so Explorers has about 60 million unique lives. It represents all 4 US Census regions. And the big strength of this database compared to other population databases is that all insurances are included. I would say that things such as the market scan usually includes commercial insurance. Some other databases only include Medicare. So the big strength is our database represents people of all paying types. And so what we did with this database was use a validated algorithm to identify those with HIV. And This algorithm entailed using an IC9 or 10 code related to HIV, as well as the requirement that they must be on antiretroviral treatment. From this, in order to make sure our data was of high quality, we excluded those with age, those were missing data on age, sex, race, or BMI. We were able to identify around 39,000 persons with HIV, 10,000 of whom were women and 29,000 of whom were men. Our statistical analysis was as follows. We performed multiple logistic regression, controlling for age, sex, race, obesity, smoking, hypertension, hyperlipidemia. And the outcome was type 2 diabetes, identified through the use of an IC9 or 10 code. There's a lot of variables at play here. I just want to say that all these variables were validated by our team in a prior manuscript that is cited below for people's reference. And so here are the clinical characteristics of the cohort that we identified. I just want to identify some drastic differences between the two that should be considered moving forward. First, women with HIV were more likely to be Black. And second, women with HIV were more likely to be obese. Lastly, prior to any statistical analysis, the prevalence of diabetes was higher among women with HIV than men. And so here we begin to graph the prevalence of diabetes stratified by age, sex, and HIV serostatus. And what we see here on the left is what's going on with men with HIV, and that the prevalence of diabetes between men with HIV and men without HIV is largely the same. But then we look at women with HIV, and we see a much completely different story, that across all age subgroups, the prevalence of diabetes is higher among women with HIV. I think at this point, our group was shocked or seemed stunned, and we were excited in regards to what we were finding. But in reality, there were many confounding variables at play. And so we looked towards our multivariable logistic regression to better understand. And I think it's at this point where our jaws dropped, that after controlling for all our confounding variables, women with HIV still had a strong association with diabetes, whereas for men, there was still no association. And so this result here gets across that diabetes now might be associated with women, but not with men with HIV. I want to take this one step further, in that we then did another sex stratified analysis and then looked at every subgroup of interest. I just want to go through maybe an example here to get across what this figure is showing. So in here in red are women with HIV. And what we did was look at women with HIV that are aged 18 to 44. We controlled for all confounding variables to help identify how much does HIV infection increase the odds of diabetes among those who are 18 to 44. And what we found is that it's higher, and that it's higher in actually every subgroup of interest. And it's more, and the magnitude in which it's higher is more so than men of every subgroup of interest. So hopefully this continues to get across the idea that HIV infection in women increases the odds unanimously or ubiquitously for women, but not men. And so conclusions of this study. This is probably one of the largest, most diverse cohort of people with HIV ever studied. We used validated diagnostic codes and we controlled for many confounding variables. And our finding is, with those with HIV infection, diabetes is associated with women, but not men. And so could our study be paradigm shifting in the sense that once upon a time, the reason people with HIV got diabetes was because of toxic antiretrovirals? But are we coming to a point where diabetes and HIV is more about excessive weight gain and excessive inflammation? And so lastly, part 5, where are we to go from here? And so there are many questions now that we should ask. First and foremost, studies have shown that diabetes is a strong indicator for the development of other diseases. Dr. Latender in Corey 2021 showed that diabetes was a risk factor for the development of neurocognitive impairment. And so can we say that because of the sex difference in diabetes, that there's going to be sex differences in many other chronic diseases? The second thing to mention is that why is it women with HIV are having excessive weight gain and excessive inflammation? Is sex steroids at play here? And if so, what does this say about transgender women receiving feminizing hormonal therapy? Are they also going to experience these unequal impacts of obesity and metabolic consequences? What do we do about guidelines? Right now, in the IDSA HIV MA guidelines, there's no disease that is different manageably between a man or a woman. but should we start looking to see whether that should be changed? Is there any reason to think that diabetes might be screened earlier among women than men? And lastly, a lot of this weight gain needs to come about from very specific ARV regimens. Should we start making decisions on ARV treatment based off whether or not they're a woman or a man? So these are a lot of questions, maybe for discussion, none of them that should be answered now. But I ask these questions mainly for one reason: to appreciate that we are still very much in this uncharted territory, and that no one knows what it means to age with HIV, and that it's important for men, for women, for gender minorities that we continue asking one question, and that question is: are there consequences? So I just want to take a moment and do some acknowledgements. The two people on the right, I'm sure everyone is familiar with, and I don't need to sing their praises anymore. I just want to thank Mr. Andrew Strunk, who has taught me everything I know in terms of the use of population databases, how to design a study, and how to interpret data. And Dr. David Calver, whose generosity is the reason we are able to use the Explorers database and take it to the next level. And that's all I have.
Thank you, Morgan, so much. Sorry, I feel like I'm hearing myself. I am. This was such a great talk. I think a lot for us to think about. I'm going to open it up. There was only one question that came through, which you answered, but I have a feeling others will want to bring things up. So please, and if you're willing to show your face also, so Morgan can see who he's talking with. I'm going to open it up to the audience.
Hi, Morgan. Jill, forgive me. I'm not going to show my face. I'm not prepared to be seen. Hi, Morgan. Great job. That was a fantastic talk. My name is Gigi Blanchard, and I am the main physician for our FEMON program. So we are absolutely seeing what you're describing. So some thoughts I have are, just the interplay of, the socioeconomic issues that women face. Women with HIV tend to face a lot of our women really struggle financially, and they're the primary caregivers for their families. And so I absolutely believe that there are these sex differences with obesity and access to healthy food, and the time, a lot of my patients work 2 jobs, and, trying to get them to diet and exercise is just not, it's just not feasible. And so I think that would be an interesting thing to look at. And, just as the pandemic has raised the issue of childcare and how it impacts people. And then I guess those are my main thoughts for right now, but great job. Thank you for focusing on this. It's certainly, the other challenge I think going forward though, is it's always hard to get these women in, for the same reason it's hard to get them to focus on their own healthcare. It's hard to get them into studies. So I think it's going to continue to be a challenge to elucidate all of this, but perhaps there's room for future collaboration, and there are lots of areas to explore further. So thanks for your great presentation.
And I'm just going to play devil's advocate there, because I think what a lot of things you're talking about there, Gigi, are gender differences. This is where I think it gets really confusing, and Morgan, maybe you have more to say about that, but there is that overlap. But what Dr. Blanchard was just talking about really relates more to subscribed gender and the roles that people have to play, and not necessarily.
How about as gender impacts sex?
Yeah, no.
Would you be happier with that, Jill?
No, I think it's hard to sort of slice that out, right? But anyway, I'll let Morgan respond to that, and then there are a lot of other questions coming through, so we can switch over to that.
Absolutely. Thank you, Dr. Blanchard, for those kind words and the question or the comment. Without a doubt, gender differences are at play. And I think we can all convince ourselves that's the case based off where in terms of how the weight gain disproportionately impacts, Black women. Why is that the case? Why would Black women experience more weight gain than their non-Black counterparts? And I think gender, societal factors are at play. And that's something we should, of course, consider moving forward.
All right, I'm going to ask some questions from here. Dr. McCutcheon asks, does your data set contain measures of diabetes control, for example, glycosylated hemoglobin? Have you examined differences in control by sex?
Absolutely. So I would say this database has a lot of strengths, but it also has a lot of limitations. And unfortunately, having good lab data is something that's missing from the database. So ideally, we would have, in addition to how well controlled their diabetes is, we would also want to look at their CD4 count, their viral load. But unfortunately, all this data is not available in the database at this current moment.
Okay, Dr. Matthews asks, did you estimate attributable fractions for diabetes among all the risk factors? HIV, BMI, age, smoking, etc. Sex is not usually modifiable, but other risk factors are.
So we did. And so I didn't include it here, but we did look at all these other factors and see how strongly they associate with diabetes. What is surprising is that women with HIV had the strongest risk for diabetes, and that they were 30% more likely to have diabetes after controlling for all these other confounding variables. And then in the other risk factors, we did not find anything that was that strong. But I agree with you that the way we're really going to have to deal with this diabetes epidemic in women with HIV is to look at the modifiable risk factors and see what we can do about those.
I'm going to ask Shannon Balcom to unmute herself because she's asked a few questions. Shannon, are you able to do that?
Sure. I'm one of the HIV pharmacists. Great job. Thank you. I think a little bit about, how much the standard American diet impacts some of this, in these different groups. Did you see anything that looks at, Black women in Africa as compared to Black women in the US? Is there a difference there in terms of the, the standard diets in the different regions of the world and how that's impacting some of this?
Absolutely. Thank you, Shannon. So I would say the ADVANCE trial is probably most indicative of what's happening in sub-Saharan Africa. So that trial was done over there. And that excessive weight gain that we saw in the ADVANCE trial was among those in Africa. So without a doubt, I think diet is playing a role here in the United States, but this weight gain that we're seeing is across the globe. And I feel like there are many developing countries, people with HIV in developing countries that are experiencing this weight gain. I also want to mention, I see Tom's in the chat, did not know he was here before. So there's a lot of questions here. Tom, feel free to answer them as well. Or chime in when you ever have thoughts.
Thanks, Morgan. And just, first up, terrific talk. And this is a big advert for you as someone who has, so much potential in this field. And it's been great to work with you. One thing was there was a question about the sex differences among the controls, I think from Alan. And that was that we, in fact, men had, when we controlled for other variables, had a slightly higher risk of diabetes compared to women among the controls. And so there was, there was a strong interaction between HIV and gender, and sex, sorry. Thank you, Morgan, for highlighting my language problems. And so leading to the difference among persons with HIV. So that was the only other thing to add there.
There was one other thing I was just going to comment on. I hope I didn't mishear you. Is early in your slides where you said it was when you were looking at viral load, the viral loads compared, the differences between men and women and their viral loads, and you said that people wouldn't be started on ARVs based on a viral load threshold. And I don't think that's the case. I think it was always CD4 threshold, unless, and someone can correct me, I'm not aware of there ever being a time where it was based on viral loads, but maybe there was a period of time. The data I know is based on CD4 count, but maybe I misheard you. So.
No, so I really did mean that it was done based off the viral load. Unfortunately, I was only 2 years old when that study was performed, so I'm not too sure how HIV was treated at that time. But would anyone else be able to comment? You know, I think
I asked a few people in the chat. I was like, can anyone comment? And I'm showing my age.
I do think in that paper, so that paper Dr. Todd Sterling published in the New England Journal of Medicine, they did mention that, you know, a big reason why they did that paper was because of the decision to start ARVs based off a certain viral load.
Okay.
But again, I think there are many people here that probably did take care of HIV during that time, and would love to hear their thoughts as well.
Anyone? Oh. Maybe they're just.
It was CD4 triggered. It wasn't viral load. The thresholds were based on CD4 count, which was the problem when it was recognized. You know, viral load measurement came into our armamentarium much later than CD4. So most of the early treatment thresholds were based on CD4.
Just a reminder for people to mute if they are not talking. I don't think I can mute people other than myself. Thanks, Dr. Matthews. So I don't know what that was showing. I just wanted to make sure people were aware that it was CD4 that was being used, but maybe there were certain places where that was somehow the data they were getting, but maybe they were also using viral load as a proxy for CD4. Anyway, okay.
So it is authorized,
actually. It's me again here, if no one's got anything to say. So Morgan, I don't know if you have had any thoughts about, you know, future work that you'd like to do. Obviously, there are some great cohorts that are available here at UCSD, like the Scenics cohort, that have stored serum samples that could be used for, you know, biomarker evaluation and then the risk of diabetes. And then equally, we have collaborators who are, you know, looking at anti-inflammatories in terms of trying to prevent things like cardiovascular disease using like tocilizumab, anti-IL-6, and thinking about outcomes from that, and whether there's any potential therapies to, you know, to address this increased risk of, you know, comorbidities with aging. Do you have any thoughts about that?
Yeah, all sounds very interesting. I think, you know, trying to discover new therapies to help lower, you know, or to mitigate the risk for these comorbidity development would be very interesting. You know, I know that people use aspirins, metformin, even statins are common, but I think there's so much more we can do, and I think that'll be interesting to investigate. You know, a lot of the future research we're doing from here in terms of epidemiology, you know, I think there's so more work to be done. You know, I think there is an under-recognized obesity epidemic among women with HIV. I feel like the next study would be using our database to kind of help illustrate that women with HIV are 2 times more likely to be obese than men with HIV. Because of that, there might be many metabolic consequences that we are just not appreciating at the moment. So I would say that some more epidemiology research first, but then of course the goal is to eventually get to the benchtop and hopefully use some of those cohorts to really figure out ways that we can improve our care.
And I'm sorry, I did not see a hand being raised. Thank you, Jeff Taylor, for noting or nudging me on that. Jeff Taylor has a question for you, Morgan. I'll let him speak.
Well, it's more a comment than a question, but great work.
Jeff, we can't hear you.
Oh, okay. Can you hear me now?
Now we can. Now we can.
I think I inadvertently covered my microphone. So I was just going to say that as, you know, an advocate who's been working with the ACTG for 25 years and engaging them on this and not really seeing the needle move very much has been really frustrating. So I'm glad to see you highlight this, and especially the study from Croy showing how few sites, you know, some didn't even report women, and other studies didn't do any analyses. And that's because they never enroll enough to be able to do a real effective analysis. So I think, you know, what we need to do is become advocates for this and insist that the, you know, conferences like Croy do report out on this, not accept abstracts that don't have that data reported, And then in the designing trials, making sure that they enroll statistically significant numbers of women and making that a requirement and making that a primary objective, and having the funders, especially the ACTG, and they've been, Liz Barr and others on the Women's Health Committee have been advocating for this for decades, but really making sure that they don't get funded unless they're looking at women as well in statistically significant numbers that can provide examples. Same with the FDA, and I'll stop there, but it's kind of my call to action. Thanks.
Just a comment. So Mr. Taylor, I don't know, I actually recognize you as the guy who interviews people like Freud, and I've watched a lot of your YouTube videos. So just as a FYI, it's actually nice to see you. That I didn't realize you're at UCSD. So very cool. Very.
And I just put in the chat a really cool study that just came out from the ACTG in combination with the women's CSG about using dedicated women's outreach workers, or WOWs, to recruit women. And if you have time to look at it in the chat, because I think we've had this discussion in the past that recruiting cis women for studies is very challenging, related a lot to the some of the reasons that Gigi alluded to, but that there are ways to do it, and we really have to keep doing that for our studies. And then this is a question, I don't think to Morgan, maybe to Jeff and anyone else from the ACTG. I certainly can't. Newer diabetes and obesity treatments like GLP-1 agonists may be promising to study in this population. And I certainly know that providers are doing it, on a patient by patient basis, but is the ACTG doing this? And that I'm not sure of. I'm gonna tag Susan, but maybe that's not fair.
Not that I'm aware of, but
okay.
Yeah.
But that's a great point, Chris. Well, we are almost at the top of the, Dan always comes in just.
So, Chris, I do know there is Grace McComsey is doing a study looking at NAFLD with semaglutide. So I think that there may be some data kind of related, but a little bit different.
Thanks, Dan. And Larry, okay, good. We're finally getting maybe a comment. When viral loads first came out, I would not start meds on long-term non-progressors with low viral loads and CD4 of greater than 500. But I'm going to guess it was not for people above 1,000, because I think that was the first threshold. So I hope it wouldn't have been that someone had a viral load of like 5,000 versus 20,000. But yeah, Larry, I don't know if you have any comments you want to make about that.
I would monitor is what I would do. And yes, if it stayed mostly above 1,000, it might get a blip up to 2,000 or 3,000, but I wouldn't worry about it and check a viral load again.
Yeah. Right. Thanks
because mostly people didn't want to start the toxic HIV medications. And so there was pressure from patients not to do this.
Yeah, it's a really important point to make. Thanks for saying that, Larry. All right, well, it's 8:59 now. Maybe no one's going to interrupt, or not interrupt, but say things now. This was great, Morgan. Seriously, I think such a thought-provoking talk. Your research is great. I know we all have very high hopes for you, and we're very excited when you're going to be joining us for real in a year, or really. And then we can really put you to work. No, I'm just kidding. But everyone, thanks for joining. A reminder that we have no high rounds next week. I think everything's turned into a very long weekend, or extra days for people. So make sure to enjoy them. And we'll see you back on, I want to say, July 9th, something like that. But enjoy the week and the weekend. And Morgan, thanks again for the really stellar talk.
Thank you for the opportunity.